Alrighty, good morning, everyone. I'm going to call this meeting to order, the meeting of the Healthcare Services Review Committee. And today is, I think that date is wrong. That's a presentation date, yeah. September 20th of 2023. Call the meeting to order. And the first thing I'd like to do is take a roll call. Kristen, if you can please go ahead and take a roll call.
Supervisor Canepa.
Here.
Supervisor Ding.
Here.
County Administrator Wilverding.
Here.
Ed Kiernan.
Here.
Jeff Wolkamp.
Here.
Rick Castro.
Here.
Abe Nunez.
Here.
Chris Zuniga.
Here.
For the record, Jennifer Van Stein will be joining me momentarily. Brandy Hopkins, Greg Diedrich, and Quinny Macedo are unable to join us today.
Thank you, Kristen. Okay, thank you for the roll call. And just to go down to item number 3 under the procedural items is the reintroduction of the committee. Why are we here? And what is our goal? So just a little bit of a historical perspective, as several of you know who were on the Healthcare Services Committee that we had previously. That committee was disbanded in July of last year. And there were 2 reasons for that. The primary reason at the time was we were informed it was a Brown Act meeting, and we had not been aware of that up to that point. In conjunction with the implementation of our management services agreement with the hospital on July 1, we had a lot of balls up in the air. There was a lot of transition of management. Our controller at the time had left. And Abe was not on board. We had an interim, I believe, at the time, and so we decided to conclude those meetings until things changed. In the interim, what we found out is as we were reviewing our clinics a little more closely, that there was a portion, and I don't have the exact section in front of me right now, that required, as a part of the co-applicant agreement with our clinics, that we have a monthly healthcare services review committee of this configuration. And as you can see from what we're doing now, it is a Brown Act meeting. We are Brown Act compliant. We had a published agenda, and we will be following Brown Act rules from this point forward. What I will say about where we are now is this is the way it was intended to be set up in the management services agreement that we have with the clinics. So I will say happily, for the first time, we're doing things the way we should have been doing them all along. So that's why we're all here. This is why we're doing it the way that we're doing it. And if there is any questions, I'd be happy to take them from the members of the committee now before we move forward in the agenda.
So this will be monthly?
This will be monthly. We're following the pattern that we had done before. We do it the 3rd Wednesday of every month. And the reason we hold it at 8:30 in the morning is because we, like you all, are all here from different locations. It gives you a little bit of time to get to the office. We are having it now on the 1st floor. We used to have it upstairs in the conference room. and it gives everybody a chance to get settled in without chopping their morning in two or something in the afternoon when we're all headed out in different directions. So that's essentially going to be the schedule, unless there's any sort of issue with that. Uh-oh, okay. Is it the Lodi thing? Okay, thank you, Supervisor. All righty, moving on to action items. We do not have any action items scheduled for this meeting, so we'll move on to information and discussion items. And first up on the agenda for item number 5 is from our clinics, and it'll be presentation of June and July 2023 financial results from Chris Zuniga. So Chris, if you want to take it away.
Yes, thank you, Jay. Good morning, everyone. It's a pleasure to be here. My name is Chris Zuniga, and I serve as Chief Financial Officer for SJ Health. I've been serving in that capacity since January of 2020. And just a little bit about me, I've been in healthcare accounting for 17 years. 7 of those years were at a for-profit hospital, and the last 10 years have been in the FQHC space. I served as a controller of the hospital. Then I transitioned to Ultimate Health Services Corp., which is California's largest FQHC, 43 medical dental clinics, fully functioning IPA, and 6 PACE sites, Program for All-Inclusive Care for the Elderly. Transitioned to be CFO at a smaller FQ at that point. And then from there was recruited by Whitfley, which is a public accounting firm, which has a very large space, very large presence in the FQHC space here in California. And that's how I became engaged with the clinics here. Subsequent to that, Whitfley, as a result of the pandemic, laid off their healthcare practice, and so I contracted directly with the clinics at that point and started my own business. I own a small consulting firm called Healthcare Management Strategies, and currently we have 2 employees. So pleasure to be here. That was a little bit too much. The presentation date refers to the day we presented this to our board. We're going to be talking about the June results, the July 23 results, and then we're going to do a small discussion on QIP, or Quality Incentive Pool Program. Alrighty, for June, we're going to be talking about our healthcare membership, our billable visits, our income statement, balance sheet. We're going to talk about our AR and collections. We have some HRSA financial metrics that we're required to report. And then there's some industry benchmarks that we measure ourselves against. I'm not going to go through the entire thing in great detail. We have a ton to cover. Want to be respectful of the hospital's time and their presentation time as well. So if we could just hold all questions to the very end of this very long presentation, I'd appreciate it. And hopefully in that time, some of the questions that come up will be answered later on in the presentation. Okay, this first slide, folks, is a very busy slide. It's got 4 quadrants on it, but the area that we focus on for the purposes of this discussion is in the lower right-hand corner. And that is our trend line for managed care Medi-Cal membership through the Health Plan of San Joaquin. We are a 2-plan model. There's Health Plan San Joaquin and HealthNet. This speaks to our Health Plan San Joaquin membership. And it's the direction that we're interested in, or the trajectory. And you'll find in my presentations, trends are very big with me. So we'll see that throughout. The direction is going upwards, and we've enjoyed an upward trend in membership for the better part of 3.5 years since the pandemic. And that is due to the public health emergency and the state halting what's known as Medi-Cal redetermination. That is the process by which Medi-Cal determines eligibility for Medi-Cal coverage. And so that was halted during the emergency, and it's now resumed. As a result of that resuming, we expect and have budgeted for a reduction of membership and assigned lives, as has Health Plan San Joaquin. Okay, this is a chart, and we love charts because they say a huge story with, and it's easy to understand. So what we're looking at, folks, is 3 years of billable visits, and this is really work being done. This is a chart that every FQHC wants to see and tries to produce. So billable visits over the course of a fiscal year. You can see the gray trend line is representative of fiscal year 21, the orange is fiscal 22, and the blue is fiscal 23. You'll see regularities and seasonality in the movement of those trends that we expect. And so, but what we try to do is move the entire graph upward in our business. Billable visits is the core of our business. Our payer class mix, the single most important financial class within that payer mix is the population I just spoke of. It's the core of our business. It's the Medi-Cal managed care population. And you can see in the grid in the bottom right, it comprises 77% of our billable visits. Okay.
So Chris, one question. So on the graph here, if I were just to look, I'm assuming those are those ending or average numbers on the right, the 12,000, the 10,000, and the 9?
Great question, Jay. Those are the July numbers for 3 years. So the most recent is that 12,300, or excuse me, the June numbers for 3 years.
Okay.
And June 2023, we had 12,328 visits.
Okay. So your volume of visits is increasing like 10% from the 3 years ago to 2 years ago, and then 2 years ago to 1 year ago, it was jumped up about 15%. Is that about a fair?
That's about right. When we took a look at the data, it's at least 8% every year for the past few years.
Got it. Thank you.
You betcha. Okay, folks, this is a representation of our profit and loss statement. We are going to concentrate on the fourth column, which is the entire year, which is why we're presenting the June results. We want to just speak to the previous fiscal year. For operating revenue, we had 23.3 million in net patient service revenue against a budget of about 22 million. So sort of similar to budget. We fell short on our visits, but the average collection per visit was higher than what we budgeted for. We also were able to recover about $2 million from the state of California related to our fiscal year 19 PPS reconciliation. PPS reconciliation is a required reporting by every FQ for every FQ clinic that has its own PPS rate. And the PPS rate is the basis of our reimbursement. That acronym stands for the Prospective Payment System. And we go through a process with the state of California. That department is called Audits and Investigation, and they are in charge for setting reimbursement rates for FQs per clinic. So there's a reconciliation process associated with that. We have supplemental revenue, otherwise known as QIP revenue, of about $12 million. Capitation and incentives of 8. Grant revenues came in much better than budget at 5.7 million. We established about 3 years ago a 340B pharmacy program, which was not in place here in the county. And we realized almost $2 million last year from that program. Our MOU and other income totaled just under $1 million. So total operating revenue on the year was $52.2 million against a budgeted $49.2. We got about a $3 million favorable variance to budget on the revenue side, largely due to the performance of grant revenue and our net patient service revenue. On the expense side, folks, our labor.
Chris, can I ask one more question?
Oh, of course.
On the PPS rates, you said they are by clinic.
By clinic.
Is that one PPS rate for the, our clinics in general, or is it by each clinic within our system?
Fantastic question. So we operate 7 brick-and-mortar clinics, and we also have a mobile unit. Each of those 7 clinics have their own PPS rate.
Okay. Thank you.
You bet. So our labor last year, we came in well under budget with the environment we were operating under. There was just a lot of uncertainty, so we did not fill all the positions that we were approved for in our budget, and that's how we realized tremendous savings on the labor side. It was a business decision. For the non-labor expenses, they essentially came in line with expectation, except for other expenses. Prior to fiscal year '23, we were placing everything that we purchase via our MOU with the county and the hospital and behavioral health into purchase services. And that's why you see that $6.6 million number, which is budgeted there. And you see a favorable variance against that budgeted number because we were able to attain, we've been working with the hospital and they've been able to give us more detailed sort of coding with the expenses that we were being charged. So we went ahead and distributed that to the appropriate expense categories based on the information that we received from them. And that's why there's a bunch of red and larger numbers in the variances, but it's because we were more accurate in our categorization.
Good question. What's the capitation and managed care incentives? That's $2 million.
Yes.
What was that one?
Yes, so capitation is an idea based in managed care, and it has to do with that same managed Medi-Cal population. We have an agreement, a capitated agreement with Health Plan San Joaquin, and they assign us lives, and what they do is pay us a monthly amount of about $11 to $12 per enrollee, and that's called capitation, that monthly check. And then the other part is incentives associated with various programs through the state and through managed care. In this case, the bulk of our incentives were paid out under a program called ECM, or Enhanced Care Management, that we have an agreement with Health Plan San Joaquin for, and their IPP program. So that was that, like $2 million in incentives there. Other expenses, that comprised of $3.4 million in a variety of expenses like repairs and maintenance, utilities, insurance, miscellaneous, $1 million in rent. We received $2.3 million in allocations from the hospital. And then as a move for conservatism, in the presentation of our financials, I accrued about $2 million in just accrued expenses that we will find later in the presentation on our balance sheet under deferred revenue. And that sort of journal entry has been reversed for purposes of audit and our submitted trial balance for audit. And we are currently under independent audit for this fiscal year. Oh. Did I hear a question?
Question. Am I okay? Okay. He doesn't like the way I talk into a mic. It just seems to me don't you normally break that down on a balance sheet as far as, I mean, that's a pretty large chunk to throw under other as opposed to, I mean.
It's a conglomerate of many expenses, utilities, rent, minor equipment, insurance costs. So
I'm just used to a balance sheet. I mean, those are, separate. I mean, so you know what you're spending on rent, you know what you're spending on insurance. Usually you don't clump them all together under other. I mean,
yeah,
that's a major.
It's for simplicity in presentation. We can certainly have a more detailed breakout of these expenses, and that's not at all a problem. But
And then I had one other question too on the professional fees
yes,
versus wages. understand, I'm coming in here at ground level, so I'm still trying to figure out what the heck the difference between clinics and healthcare services and everything else. Break down for me, I understand the employee side. You would be listed under,
I am
Professional
in
fees.
professional fees, that's correct.
okay, so your W-2'd employees would be the only thing listed.
In salaries and wages and employee benefits, that's correct.
Okay, thank you.
Yes, sir. Yes, you know, I go through these presentations pretty quickly because I present this every month to our board, but for a lot of the folks in this room, it's the first time looking at this, so please keep me honest, folks. Net income for the year, by the way, unaudited, is 5.7 million. Okay, this is a trended balance sheet. We begin with the end of fiscal '22. We call that period 0, and it's trended for the year. And on the far right is our June 2023 balance sheet. Some items of interest. The other assets category, which is featured here. You could see in the beginning of the year, it began at 23 million plus, and then right around April, it dropped by about 15,000, and it got turned into cash. And what that is a payment that we received from the hospital associated with our QIP program, and our due to from account. The hospital received funds from the managed care plan, and then they forward our portion.
Excuse me, it's really important for me to say, because this is gonna be an area that we need to make sure that this committee understands. Quit money is not given to any FQs. Quit money is hospital money. And we checked on all 21 FQs in the state. We checked with 6 or 7 of them personally. We checked with the other 16 through our professional fees. And that's just not an accurate statement. QIP was developed because if we do things right, patients stay out of the hospital. And because they know the importance of the public hospitals, they said, look, if we're gonna do things right in population health, we gotta make sure that the public hospitals don't suffer either. So if you hit those metrics, you receive QIP money, the hospital does. And to give you the best example, CMC is the other FQ here. They have no QIP dollars because they have no hospital partner. But the QIP money does not, in any case, except in this county, go from the hospital. That supplement is too big for a hospital that serves a Medi-Cal population to give to an FQ.
Well, CMC doesn't enjoy QIP money because they don't have an agreement with a public hospital.
Correct.
Yeah, so
But no-
there's that distinction.
But no hospital, none of the 21, give their QIP money to the FQ, none,
And-
0.
And
So
Rick, while I think there's a section on quit money
Right.
further down in the presentation. I think what Chris is just doing is merely explaining, because I had that as a listed item on how did that jump around? What's that? Yeah,
Important item, I want to make sure that's understood and called out when we go through these financials, because they look good, but realistically, that's the hospital.
so let me ask, essentially, this is the accounting machinations that happened.
That's
And, you know,
correct.
we have an agreement with an
That's correct.
MOU. It is what it is for right now.
That's right.
And this is just tracking with that. We can discuss the merits of the MOU factors, and we've had that conversation before. I don't want to get us, I understand what you're saying. I think we all do.
Yeah.
But-
And the only reason I'm calling it out now is because it's shown here, and I want to make sure as we go through these financials that we're understanding that piece of it. It's very important to the hospital. That's my point.
No, I hear you. I mean, it's 50% of their revenue. If we wanted to
little
flip
less than
back
that.
here, I didn't want to open that can, and I'm not going to. I'm just gonna say, it hasn't gone unnoticed. It just, for discussion purposes, I think we need to just get through the numbers as they are.
Thank you, Jay.
Thank you,
And-
Chris.
And that will be totally highlighted later on in the presentation.
Thank you.
Okay, so 20.7 million in cash. We've got other assets of 9.8 million, total assets of 36.1. We've got on the liability side, other liabilities of 5.4 million. Deferred revenue, that's the deferred revenue that I was referring to earlier. 2 million of that 3 million is just a conservative accrual, and 1 million has to do with deferred revenue associated with our grants. Total equity for June 2023 is $27 million, and total liabilities plus total net equity is 36.1. Gonna skip the next two slides, folks. That's for your reading, and it goes into the details of our P&L and the variances to budget. This is a very busy slide. I'm gonna go very briefly through it. This is our accounts receivable aging. So this follows a very typical aging schedule where you expect the higher balances to be the most recent, and then in an FQHC, we expect the higher of those balances to be in the Medi-Cal financial class, and that follows what we would expect. Is a stark contrast to where accounts receivable was when I first got here. Today we're at 37 days net AR, and back then it was something like 160 or 180 days. It was terrible when I first got here. So definite win there. But let's look at more graphs because everyone can understand.
One quick question, Chris, and I went through the whole packet previously, and I know that 37 days dropped back down in the subsequent month in July. So was there an anomaly that went on in June? Because it's out of trend. If you see it jumps up 37, and then it comes back down in the following, or the next month, rather.
Good observation. The state of California, every single June, stops making disbursements when the budget approval process. Once their budget is approved, they resume payments. So like the last 2 weeks of June, you're not expecting to get, and you don't get anything. And then you recover that in July when they resume.
Kind of what our auditor's office does when we have the end of the year, right? Yeah. You guys. Thanks, Chris.
You bet.
We want to overload our purchasing.
Okay, so this is a chart of our collections by our vendor, EMMI, on a date of service basis for the last 3 years. And again, just like billable visits, what an FQ desires to do is move that trend line upward. And you can see that here. And the most impactful piece, again, of our collections at 80.25% is our Medi-Cal managed care financial class. And that's true for every FQ, guys. But Medi-Cal as a whole is like 93% of our cash collected. When we juxtapose our billable visits against our cash collections, we really see work in progress. This is what I do for a living. So whenever I go into an FQHC, I preach productivity, visits, but then again, we have to collect on those things, on those visits. And so when you see these trend lines and they move very complementary to each other, that's what you would expect. You don't want to see trend lines that are not moving with each other with regards to visits and collections. And we've achieved that here. We've achieved that, and we've also achieved the increasing of both visits and collections. So that's a
Can
big,
I just interrupt you for a second?
Yes.
Understand that this is a first meeting.
Yes.
And we're in a learning phase. In my old life, there'd be a bowl on the table, and every time you said FQIPL, whatever, you'd throw in $1. I have no idea what FQ and everything, if you could just at the beginning when you bring them up, just give me what it stands for, and maybe in 8 years I'll figure out what you're talking about. Thank you.
Thank you, Supervisor Ding. Great point. And by the way, thank you so much for your assistance with the Lodi Clinic. Very excited about that. So FQHC stands for Federally Qualified Health Center. This is a niche market in healthcare, It's a very small, specialized field within healthcare. If you know hospitals, if you know medical groups, you don't know FQHCs. It's just a different reimbursement model, a very large set of compliance regulations that are set by a federal agency known as HRSA, Health Resources Services Agency. And so when we speak about PPS rates or HRSA or FQHC, please feel free to stop me. I will try to remember to explain all of our acronyms. The Federally Qualified Health Center world is an acronym-rich area, and for those folks that are just learning and just being exposed, it can get pretty daunting to keep track of all of that. So thank you, Supervisor Deng. Okay, so, and by the way, the June presentation is a lot longer and more involved than the July, and so it'll get quicker from here. This is a trended depiction of our required financial metrics that we are supposed to present to our board of directors. This is two statistics: cumulative cost per unique patient and medical cost per medical visit. And what this depicts is the costs per patient or medical visit over time. So the cumulative cost per unique patient began at around $1,000 fiscal 21 and has grown considerably in fiscal year 2023. You know, pandemic and post-pandemic, inflation is real, and we see that in the data. Medical cost per medical visit as well has gone from $274 all the way up to $334. And by the way, when I mentioned that we have an upward trend in Medi-Cal assignment or enrollment for 3 years, the data does not suggest that we have an increase in patients seen. We do have a tremendous increase in billable visits, but the patients seen annually is right around 32,000 patients each one of those years. So what that means is that our patients are coming in more than they used to. And so that is also reflected in these figures. Okay, we're at benchmarking. Folks, we have a wonderful nonprofit in the federally qualified health center space.
Hey, Chris, can something you just said I'm having trouble understanding.
Yes.
You said you have 31,000 patients or so?
That unique patients that visit our clinics every year, yes.
Okay, so if we go back to, I think it's page 5, we had billable visits that were
Yes.
12,000 and change.
Yes.
So how do those two numbers differ? Because these,
Yes.
I had asked, have gone up about 10% from 2 years ago and then 15% from last year. But how are visits different from patients?
Excellent question. Because a patient, a unique patient will visit our clinic multiple times in the year. So that 31,000, 32,000 patient level equates to 140,000 visits. If you see in the grid, it's 139,438 right there where it says total in the bottom left-hand corner.
Okay.
Those are the total visits for our fiscal year. And 31 to 32,000 unique patients comprise those visits, have come into our clinics enough times to generate those billable visits.
Okay. So essentially you have repeat
3 to 4
customers.
visits per patient.
Okay. And then the 12,000 and the 9,000, those are the monthly numbers that you have at the
Back
end of the
then.
month.
Yes.
Okay, thank you.
Chris,
Yes.
how much of that increase is due to telehealth?
Oh, telehealth was a tremendous tool during the pandemic. We've backed off. That's just the nature of the business. People want to come in more now. But during the public health emergency, telehealth, I got to say, was 65% of our billable visits during that period, if not more. But we've backed off since then. Good question, Rick. Thank you. Okay, so benchmarking. There is a nonprofit that aggregates independent financial audits of federally qualified health centers, as well as, here's another acronym, Uniform Data System Reporting, UDS reporting, for each FQHC in the nation. And they you know, you can contract with them to create specific reports, but one of the things they do for free is create benchmarks for our industry. And their financial benchmarks that they recommend all boards of directors follow or monitor or oversee are these 5 here. Bottom line margin as a percentage of total revenue should be, in a healthy FQ, greater than 3%. Operating margin should be greater than 3% of total operating revenue. Our labor costs should be less than 70% of total operating revenue. Days in net patient accounts receivable should be less than 60 days, and then our days cash on hand should be greater than 45 days. So how do we fare against the benchmark? You can see that our operating margin is much greater than the target at 10%. I will say in the July report, this slide has changed. There are new numbers that were just released for 2023, and we'll go over that. And it really puts our numbers into context. But just given the standard capital link targets, we are much better than the standard capital link targets. 10% for operating margin, 11% for bottom line margin. Days cash on hand are at 165 days. Days in net patient receivables are 37, and our labor costs came in at 67% of total operating revenues.
So, Chris, on your labor costs, you have professional fees, which are you including that in
Yes,
your
sir.
labor costs as well?
We've got professional fees, yes. Okay, let's jump to the July report, and we're gonna go a little bit quicker in the interest of time. So I mentioned the notion of Medi-Cal redetermination, and it has begun. And as a result, as expected, we took a dip in enrollment for the first time in a very long time. So here we are in a whole new world, and our membership, managed care membership enrollment has fallen. Visits. Visits are still trending higher than previous years. For the month of July, we had 10,838 visits. Again, the single most impactful piece is our Medi-Cal managed care. You're going to see that through and through. But from a seasonality perspective, we are still higher than the previous 2 Julys. This P&L, or income statement, is much simpler than the previous. Our 10,000 visits resulted in $1.7 million in net patient service revenue. We had QIP revenues, our Quality Incentive Pool Program revenues of just under $1 million, which is what we budgeted, so that's going to be a recurring figure likely. Capitation, again associated with our managed care population, was at just about where we budgeted. Grants, this is the area that needs to be focused on in this month's report, and definitely from an operational standpoint. We budgeted for $460,000 worth of grants, and we only came in at less than $100,000. Now, grants are a unique vehicle. These contracts, you really tend to see the revenue recognition towards the end of the budget period, but what this signifies to senior leadership is that we need to have discussions with our grant teams and make sure that they are performing on their contracts. So we've done that. We just got the results of August, and as it turns out, those results are not much better than these. So we really have to take a look at what we're doing from a grant perspective. Again, you just saw the results from June, which were fantastic from a grant perspective. You know, you come into a new fiscal year, and we just need to figure out what changes we need to make and see where our opportunities are and improve our grant administration as a whole. But you see that unfavorable variance of $360,000 flow right to the bottom line. This is our first loss in quite some time, $141,000 loss. I don't think we've had a loss in 18 months. And so that it's critical that we get the documentation and perform on our contracts to recognize revenues in these grant programs. That tells me that I've been talking for at least a half hour. So I'm going to speed it up even more. Again, these are more explanations to the variances on our P&L. Our balance sheet does not look much different than it did at the end of June. So not much to highlight here. Accounts receivable, again, very healthy. Our collections were $2.2 million, again, recovering from that halt from the state. And here we are again with our trended graph. These are by date of service for 3 years. And here's the visits versus the collections. And you can see, those blue lines are almost exactly the same. Okay, this HRSA financial metric, these two, they get more robust as the year progresses. So these initial figures in like the first half of the year, they're not as robust as they will get to be. Now, this is what I want to focus on for July. There's a lot of red there, folks. Red's not good, right? So we realized our first loss in about 18 months. Profitability is 4%, negative 4%. But I also included the results from June, and I juxtaposed that or compared that to the 2021 national median for FQHCs and the 2021 California median for federally qualified health centers. Look at the similarity between our results and theirs. And so it tells you, there's some method to the madness here, and our performance is very similar to those medians. All right, QIP. The Quality Incentive Pool Program is a managed care directed payment program that challenges public health care systems to improve equity and quality for Medi-Cal managed care enrollees via ambitious pay-for-performance targets. Those are not my words, folks. That's coming from the California Healthcare Safety Net Institute website. They are an organization that assists the California Department of Healthcare Services, otherwise known as DHCS, in administering this program. We are currently in program year 6. The QIP program is a calendar year-based program. However, every year the rules change and it's getting harder and harder to qualify for these monies. So the funds flow from DHCS to the health plans, and then from the health plans to the providers or public health systems. The reporting domains, there's 9 of them, and they are behavioral health, care coordination, care of acute and chronic conditions, experience of care, improving healthcare, health equity, maternal and perinatal health, overuse and appropriateness, patient safety, and primary care access and preventative care. This is a very complex program, and we have a large team performing, and Dr. Dulio heads that, who's behind me, for the county. The FQHC carries a disproportionate burden for performance. So if we look here, there are 20 priority measures, and all of them are FQHC measures. And then there are 20 elective measures from a menu of 32, 20 of which come from the outpatient arena, and only 12 come from the inpatient arena. And that's just the reality of the way the program is structured. The state makes distributions or payments 15 months after the year end. So for example, program year 4, otherwise known as calendar year 2021, was paid out just recently in March 2023.
Chris, are those monthly, quarterly, or annual payments?
Annual payments.
They are, so you get one big
One
lump, which is
big-
why you had the flip-flop you mentioned earlier on the balance sheet.
Yes, sir.
Okay, thank you.
No, you get the QIP allocations every month from the hospital. QIP allocations come every month from the hospital.
I think what Jay was referring to was the DHC.
The actual payment.
Yeah, and then from the health plan.
So it doesn't explain that.
So how did we get to 36% for the FQHC and 64% split for the hospital? It was very simple. The FQHC was really not the leader in this effort. The CFO and CEO of the hospital at the time calculated budget shortfalls without QIP for both organizations. And total shortfall was 42.1 million, featured in the bottom right-hand corner here. And so when the split percentage of those deficits were 67% and 33% respectively, hospital to FQ. And so the initial agreement was just that. I mean, the hospital came up with these three scenarios, 70-30, 67-33, and 60-40. And they essentially told us, okay, we're gonna do 67-33. And we really had no say in the matter and said, oh, well, okay. However, that was the purposes for coming up with the fiscal year 21-22 budget. After our 22 budgets were submitted, and through the process of the MOU and really articulating who's buying what and how much for this and that, additional IT costs and lease costs were going to be allocated to the FQHC. And so we said, okay, well, can we have a little bit more percentage to cover those things? And the hospital said yes. And that is essentially how we landed at 64 and 36. And that's it. That's how it went. Okay, so where are we
So
today?
really important, guys, for your education. That's not done in any other hospital. And my objection to it right from the get-go was the hospital was struggling financially. For them to do that doesn't make sense. And so I think the big question that I want to know, in 2021, total expenditures under the hospital was 21 million. So now we're 3 years.
Say that again?
Total expenditure for the FQ from the hospital was 21 million. We fast forward 3 years, total expense is 47 million. What is that added 26 million in expense?
That $21 million figure that you just cited does not agree with our audited financials, and they're coming up, and I'll show you. So,
Again, not answered.
program year 6, calendar year 2023. If we ended it as of July 31st, 2023, our team would be reporting 40 measures as required. 34 would be coming from the FQHC, and 6 would be coming from the hospital. So the metrics contribution is 85 to 15% in terms of how we earn these funds. But again, the revenue split is 36-64 per
Again,
the
Chris,
agreement that we
I
have.
asked the question again. There is not a single FQ that gets QIP money from the hospital, true or false?
So I'm not willing to attest to something that I don't have data on, but it's not usual to say the least. But this is the way the MOU was constructed. It's a legal agreement, it's binding, and nothing's changed from that agreement. Okay, so if we take a look at the audited results for 21, our expenses definitely were not 21 million. They were 33.9 million. Our profit, but on the QIP area for that fiscal year, we had QIP revenues of 15 million. You're going to see those revenues declining every year. In 22, the audited figure was 13.6, and the unaudited figure for the fiscal year that just ended is 12.3. Our profitability is also falling from 26% to an unaudited 14%. However, the QIP percentage as a percent of total revenue is falling from 33, it used to be 1/3 of our revenues, and now it's 23% of our revenues.
Chris, those falls are from lack of performance, correct?
So it's getting hard, as I said,
Lack of
it's
performance,
getting
correct.
harder
Lack of
to-
performance?
I think that our performance can certainly be improved, but the conditions that generated the earnings for prior program years were much more lax and favorable to the participants than they are now. So it's common to see this across the pool in counties.
So-
Although there are some counties that are doing it better, there are some counties that are doing it worse.
Listen, guys,
Um,
I want to be factual here. So it's really important that we call out, because when I came here, I envisioned population health. And I envisioned population health because we had all pieces to the pie. And so we want to be real factual here. I've told you, as you guys can tell, I'm very passionate about the QUIP money because the hospital needs it. That's the most important thing. But also in regards to performance, it's really important, and we pointed this out to you guys, what is mid-year this year, because we looked at the performance, we looked at Contra Costa, we looked at it all. The only FQ that was performing more poorly than ours was Arrowhead, the only one. And so when you look at these performance dollars, when we look at that decline in QUIP money, it's a performance issue. And when you look at counties that have this down, Contra Costa County, Alameda County, they are 100% on their QUIP opportunities. So it is doable. They are 100% on those opportunities. And again, why are we so passionate about it? Because when you look at even 15% of not making that number, it's millions of dollars left on the table. So I know it's difficult. I know it's difficult, and I know I seem like I'm here to complain, but I'm not here to complain. I'm here to make sure that we understand the true story. You're right, we have to perform better on those QUIPs. We do as a system. But we need to make sure that you understand that loss of revenue, both to the hospital, because whatever that decline is to the clinics, it is 15% higher to the hospital, right? Because, you know, we're collecting from that total pool as well. So I know from your two perspectives, this is brand new to you. And I want to make sure that we call out where we were and where we are, so only for this reason, so we can get to a better place, right? That's what this is all about. So just
So
really important.
I'd like to remark on Mr. Castro's comments, and I do want to stick to the facts, because the facts are, the performance you were citing was an estimation before the program year was over, and that was 45% on our behalf. We ended at 80, and there are plenty of counties and UC systems that performed worse than us.
What I'd
Wait, I'm not finished.
Okay.
Thank you. And so if we look at the reality of this program, it is getting harder. But when we look at the overall MOU net effect of expenses that we are paying for, we haven't talked about that at all when this QIP issue has been raised. We are spending millions of dollars. The hospital is one of our single largest vendors.
So I'm going to jump in right here because we're getting into a debate, time's leaking by, and this is a first meeting. You know, as I said in the beginning, we're not going to solve everything. There's a bunch of issues. Two things, and I want to point out, just for everybody's edification here, and especially the supervisors who are new to this, is there's a lot of history here. There's been a lot of evolution that has gone on, and there's been a lot of issues that pop up. Rick brings up some good points. Chris is trying to explain how we got where we are. We have two documents, and when we get to comments, I'm going to summarize for the supervisor's benefit. After we've gone all through this, I want to kind of do a little 2 or 3 minute walk down memory lane so that they understand how we got to where we are functionally. we're not gonna get there in the next meeting or two. Let's just recognize we are where we are right now. We have two controlling documents that are driving where we go, and while there may be issues and there may be reconsiderations of what we wanna do about those documents, that's not a today conversation. We're just trying to get a baseline here that we can move forward from. And so I wanna bring everybody back so that we recognize that, okay? Thank you.
I just have one quick question. So when we went to Dr. Perdue and he talked about what you guys bill hourly, and he said that there's a shortcoming there that potentially if that raised, that you could wean off the quip money. So can you explain, I don't know if that's outside the circle
No,
or what,
that's
I mean, that's,
totally relevant.
and how does that change? I mean, this seems
yes.
like that would be the fix to this, but is it something that's easily doable, or we do, or who does, or?
I don't want folks to leave the table with misconceptions in this regard. So one of the fiscal tools that we have as a federally qualified health center, in particular in California, is that we have the ability to manufacture a raise. So the PPS rates that I was speaking to earlier, there is a process that we can follow with the Department of Healthcare Services to increase those rates per clinic. It's not an easy process. And in a public space, it tends to be a lot longer, like 3 years down the road. But it is doable. It's cumbersome, we can do it, but bottom line is we can have higher PPS rates. Now, the second question is, does that cover what we're receiving from QIP? I don't believe it would. These dollars are large. Our P&L states what I'm about to say. We're not profitable without these QIP funds. We are more than the target, the capital link target of 3%. So there's opportunity there. And we will certainly do what we have to do or what we can do to seek higher reimbursement rates and more enrollment, for example. So our business can certainly grow and we can get more rates so that we can begin the process of shifting some of these percentage points back to the hospital. That's certainly in the realm of possibility, sir. So last thing, and then the hospital can begin their presentation, is this net proceeds from the MOU, okay? So just for the new folks in the room, it's not just QIP dollars coming our way, it's also tens of millions of dollars that is going the hospital's way. In the audited figures for fiscal year 21, 15 million in QIP for us, and we purchased from the hospital 13.6 million in expenditures. Following year, 13.5 for QIP, 11.3 in expenditures that we purchased. And finally, the unaudited results for fiscal 23, it's almost break even. 12.3 in QIP revenues against purchase services and departments from the hospital of $12 million. That concludes my presentation.
Thank you, Chris. Okay, let's move on to the next item on the agenda, which is the hospital's presentation of July financials result and the MSA deliverables. I did have one question about this. Abe, June financials, do you have a year to date? I know you're being audited as our...
Correct. Preliminary, we did hit our margin target. With that said, our pension adjustment just came to light this week, which is gonna, essentially we have to increase our pension expense due to the changes in deferred amounts and also market changes. From what Jeff shared those details. I haven't had a chance to connect with our external auditors that put those calculations together. But my understanding is that those added pension expenses are gonna impact all of our county departments.
Correct, yeah. The pension expense last year turned out to kind of be an anomaly. There were some shifts in deferrals and deferred inflows and outflows, and it's actually, GASB's gotten it way more confusing than it ever used to be. But now there was changes in expectations and investment earnings. So last year was actually a reduction in the 21-22 fiscal year was actually a reduction in pension expense. This year for 22-23, we're back to the normal. It's back to
And I'm anticipating that's because of swings in the market and the swings in our unfunded liability, funded ratio and all that, because I get to see it from the actuarial side. So let me ask this question, but we only get that information once a year, correct?
Correct.
So you guys are gonna have to be able to put an estimate in there, whatever it's gonna be, and do a true up at the end of the year.
Correct, and which this last year shows is incredibly hard to do. Because the things that the actuaries look at are not things that the normal person would think to even try to analyze. I mean, you're talking, you know, shifts in life expectancy, you're talking about shifts in.
So let me stop you right there, Jeff, okay?
It's-
Yeah,
But correct.
nobody's asking you to be a monthly actuary. What I'm saying, you're a cash basis, so to you, you wait till the end of the year and you roll it all in and off you go. They're accrual basis because they're an enterprise fund, right?
Correct.
They have two choices, ignore it or book an estimate.
Yep, I agree. The best bet to go would be to estimate an annual amount and put in a monthly accrual for that. Correct, and then you'd have a true up. But keeping in mind, the true up could be a very large swing.
And it may want to be looked at throughout the year as you see market swings. If the stock market took a crash and you're booking something that's going to be very, very light on your accrual, you may want to adjust that every quarter or in mid-year. I mean, when the county makes mid-year adjustments as a part of its normal annual cycle. But I'm suggesting you're gonna have to do something.
Yeah, so, you know, I'm fairly new to the county, Jay, as you're aware. So when I first started and saw a positive $40 million pension pickup for last year for the hospital, I said, what is going on here? And now it looks like
Yeah,
it's
last
going,
year was
it's
an
going
anomaly.
the
It was
opposite
odd.
way. So at the county level, do we have a reserve established to minimize those fluctuations in our pension?
We have an unfunded pension reserve, but it is not designed for.
Yeah.
Yeah. for
It's
the-
nothing that's gonna transfer to the hospital, it's something we keep on the net county books. And we do that in the case, and I hate to even say it right here, but in the case we had struggles in order to make our pension contribution from the employer side, we have a reserve we can dip into. We have not touched that yet.
Okay, good to know. Okay, so I'm Abe Nunez, CFO of San Joaquin General Hospital. I've been with, just to give you a little bit about my background, I've been with the county roughly 9 months. Prior to my tenure here, I worked in the Stanford healthcare system for a little over 10 years, and before that worked another 10 years at Sutter Health, supporting the San Francisco Bay Area facilities. So we're gonna start off with going over our July financial results. So first month of our new fiscal year, and then transition over and talk over some of the ongoing initiatives and successes to lift both our quality and financial metrics. So to start the year, we had a decent result. We achieved our margin target by roughly $300,000 when we look at EBITDA or our financial results from a cash flow perspective. The key positive driver there was lower than projected expenses. When we look at our purchase services and our supplies expense categories, both of them came in favorable or lower to target. In terms of our volume, when we look at the whole house, our adjusted patient days, so looking at our inpatient days plus our outpatient equivalent days based on a charge factor, we were favorable to target by about 3.5%. Our inpatient specific volume metrics were positive when we look at our patient days and deliveries. Good month in terms of surgical volumes. When we look at the acuity level or complexity of the patients that we treated in the first month, we continue to see a pickup in our CMI, meaning that we're more accurately coding for those patients, which is gonna translate to lower denials from our payers and also a lift in our overall reimbursements for those cases. Some departments that were short of target included our trauma, ED, and our clinic visits. When we look at our trauma cases in August, so the second month of our fiscal year, they did rebound, so that was great to see. And
Just to give you a little bit of that fluctuation in trauma, I mean, I had a trauma center in Anaheim. We typically saw about 70 trauma visits a month. My trauma center here sometimes eclipse 400. So, I mean, just to give you the amazingness of that service. And last weekend, in 12 hours, we saw 22 traumas, 4 gunshot wounds, 2 stabbings, and a bunch of MVAs in 12 hours. So I want to point that out because that volume's going to fluctuate. We can't market for trauma. We only get what we get. but we get it from a large section of the community, including east of us. So something we should all be very proud of, not only in the fact that the volume that they do, but the quality of that service.
And when we look at our average length of stay for our inpatients, we're pretty much on target. With that said, we still have a lot of opportunities to discharge our patients as soon as they're medically cleared by our physicians. So I know that our utilization review team is working very closely with our providers to start that discharge process earlier in the day, so that we can open up beds for new patients. Overall, when we look at our revenues, we were short of target by about 1.2 million or 2.9%. Primary reason is that we're taking a more conservative approach in recording our revenues for the supplemental payments, in particular with the QIP, considering that, our metrics are not where we initially planned. When we talk about the QIP supplemental payments, I think we need to look at it from a county viewpoint and say, hey, if we don't get to 100%, we're leaving 20% of revenue on the table at the county level, right? Not the FQ or the hospital, but that's just my viewpoint. Expenses came in favorable to budget by about 3.4%, which was great to see, considering that we still have a tremendous reliance in travelers. So we have a lot of vacant positions in our hard-to-fill clinical areas. When we look at our cost per volume indicator normalized for acuity, we're favorable to the target that we established. So that was, we'll continue to report back on that trend, but that was a good start overall. And when we look at salaries and benefits specifically, we're favorable to budget, but that's due to the high number of vacant positions we have. And travelers continues to be the biggest opportunity on the expense side. So finding ways to fill those vacant positions is going to be critical if we want to achieve our desired financial results.
So you're saying you have a vacancy savings, but the high cost. You say that you're having a vacancy savings, but the high cost of the travelers cause that number.
Correct. So when you look at just salaries and benefits for our county employees, we were lower than budget because we have a lot of vacant positions.
Okay.
So we're having to backfill those nurses through travelers. So
And
that's
a higher
increasing.
cost employee. then.
Exactly.
Okay.
Exactly.
So you're seeing it in professional services, but what it should, it almost should all be, to be honest with you, it should almost be salaries. Because a lot of those professional services contracts are our traveler contracts.
Okay.
So they really are, what we'd like to see, to be honest with you, is our salaries higher, close to budget, and a decrease in those high expense travelers that are costing us anywhere from $200 to, $150 an hour.
Yeah, so
Thank you.
when we look at our cost per CMI adjusted discharge, so cost per volume indicator, we're way lower than the other local general acute facilities. So one would think, oh, hey, we're affordable, that's a good thing, but it makes it very challenging to hire talented employees, right? Because of our salaries.
Thank you.
So here's just a snapshot of our income statement. You can see our revenues came in 1.1 million short of budget in the first month, as mentioned, but we made up for it on the expense line. So again, a lot of challenges and opportunities to lift both revenue through various ongoing initiatives that we'll get into here shortly. And on the expense side, on the expenses, continuing to try to be creative and fill those vacant positions.
But the acronym ABITA, can you explain that?
Earnings before interest, depreciation, and amortization. So it's basically looking at our financial results from an accrual basis and adding back the capital cost, right? So the depreciation associated with our facilities improvements and new medical equipment.
So Abe, before we jump to this dashboard, and I know I've sent you a number of emails over a number of months about getting an actual P&L and an actual balance sheet and an actual cash flow statement. I mean, this right here is a very, very summarized snapshot, and I can't really tell what's behind your operating expenses. The detail Rick was just talking about, we trade off, and I don't know how many cents it is on the dollar, to have a permanent employee because we're using a contract employee, whether it's a traveler or something else, it's very difficult to see. The supervisor mentions EBITDA, but that's not a net income number.
Yeah, there's an operating margin number, and then there's EBITDA margin, but yeah, happy to bring more granular information for the
Yeah,
next meeting.
to me, this is very, I know Supervisor Ding had mentioned that the other expenses were lumped into a tune of about $600,000, and that's small scale compared to the summarization we have there.
Yeah. Sure, we'll bring the more complete P&L with the various expense categories broken out. When we look at this financial dashboard, down at the bottom section, so the top section highlights some key volume indicators, bottom one, some key financial indicators, and it breaks out the expense categories. So green, we're positive to budget, red, we're short of budget. Just real quick on the volume side, we talked about our days being favorable. ED visits, trauma cases where we're red, but mostly green in terms of our volumes, which helps support the better result versus planned the first month. Down at the bottom, where you look at our financial indicators, you could see the variance to budget by expense category. I think that's what you're referring to, Jay. So you have salaries, benefits, green because of the high vacancies, contract labor, red because of the high number of travelers. And down below, you can see the net income and then the EBITDA, or our financial results from a cash flow perspective. And here's a chart which highlights the month-over-month change in contract labor, and it compares current year, so the first 2 months of this year versus last year. You could see that we're lower than prior year in terms of our travelers, but we're still considerably above the target that we established of about 60 traveler FTEs. And when we look on the right-hand side, the top 10 departments that are driving those contractors, you could see our emergency room. Historically, from what I understand, we've had a hard time filling those positions. Our nursing units, the OR, it's all the high-cost employees because of the tremendous competition that we have from private facilities for these hard-to-fill positions. Okay, so now we're going to transition into some ongoing initiatives and successes to lift our quality and financial metrics. A lot of hard work taking place behind the scenes to improve both of those areas. When we look at revenue enhancement, I know there's kind of an eye chart there on the left-hand side. Some of these initiatives are in the early stages, but we have realized a few as well. When we look at our annual strategic pricing, we contracted with a company by the name of Centauri, which does charge master reviews for hospitals nationwide. So they'll look at our pricing by department. So look at what we're charging the ED, trauma, our room rates in our inpatient units, compare those prices to market, and then cross-reference those with our payer contracts, and then identify opportunities to lift revenue through pricing changes while maintaining us at market level, because obviously we don't want to outprice ourselves. CMI, we recently started a clinical documentation improvement program to ensure that we're accurately coding for our inpatients. That's going to translate to lower denials from our payers and more reimbursements by Medicare and our CDCR payers. So essentially, we're getting reimbursed appropriately for the level of care that we're providing to those patients. We've also contracted out to an outside agency for our small balances. These are accounts that historically have not been worked due to vacancies within our billing team. Those smaller dollar balances were just set aside, and there was no effort made to collect on those balances. Now we're collecting roughly $700,000 a month on those accounts that historically were not touched.
So I want to chime in here. So a couple of things, because this is part of the whole MSA. We came in with common spirit, and we said these are some things that we know that we can do better just because by looking at the data. When you look at that CMI, it seems, it seems like a minor number, but it's not. And it's basically saying, if a patient comes into our facility and we code them properly, we are gonna get reimbursed properly. And so what you're seeing is our CMI was running about 1.4, now it's running closer to probably 2 or 2.1. And every tenth of a percentage up represents hundreds of thousands of dollars. So that was seeing the same patients that we saw before, making sure that we documented appropriately their comorbidities. In other words, what other issues do they have to make sure that we maximize reimbursement. The other thing that we realized coming in was, and I'm really blunt here, so I apologize, our revenue cycle did not exist. One of the first things that we did as a hospital is we had to go back and look at all of these bills that weren't addressed for over a year. And we had to make a decision to say, look, we're not gonna collect on these anyway. I don't know why the hell they weren't billed in the first place, but all of that cleanup has taken place, and we're seeing, so we had to put other resources in to make sure that we, number one, billed appropriately, and number two, collected on our billing. And it really, I don't know what happened in the past, but it just wasn't happening. And if you understand hospital finances, they're always 6 months past due, essentially. What you're really seeing is the payments from 6 months ago. And so what we're starting to see month over month is significant increase in our cash. And that really dictates the success of what we're doing. So for, the last 3 months, we've seen a positive trend, and we expect to see it forward. So a lot of the things that we brought to the table are from, there's two pieces to this. There's a financial piece, which we're very proud of what we've accomplished over the last year. But more importantly, there's a quality piece. Our hospital was one of 9 hospitals in the country that had a Leapfrog F, which is not an accolade you want, right? And it's had that F for years. We've already made that change. We believe at the worst case scenario, our fall results are gonna be a C. The best case scenario are gonna be a B. But most importantly, we're not one of those 7 Fs or 9 Fs that haunted us in the past. There was an article when it came out last time, San Joaquin, one of the 9 hospitals with F Leapfrog. So 2 tracks on this, financial, a lot of these are financial, but we're doing a significant focus on the improvement in our quality. And to me, financial is important because we have to stay afloat, but quality is what we want, and that's the other side that we want to make sure we're heading in that direction.
And as we transition from a fee-for-service to a value-based model, those quality metrics are going to be critical, right, to ensure we're not leaving any revenues on the table. So CMS is going to pay us more if we hit these quality metrics for our Medicare patients.
I just have a quick question. So then, of that 700,000, what percentage of that's not that seems like a large amount of money monthly. They were just letting that go for how long? That's
No, it was, the number was,
This for the small
Oh,
AR
yeah,
balances.
yeah, I
That's
mean-
just one of the opportunities that we've.
So
So they
they-
just weren't,
they weren't being worked at all. Yeah, they weren't being worked at all.
oh, that's kind of alarming.
Absolutely.
I don't know how long that fell off, but the good news is
It's back on track.
we've developed a good revenue, AVE has developed a good revenue cycle team. We're very, it's been a year. The MSA has been a year. And the most important thing that we do, I think, is first and foremost, we had no team. We had a contracted CFO that was here a couple days a week, probably doing more golfing than, good guy, but he was a contracted CFO. We had nobody in the revenue cycle team from a leadership perspective, and all of those positions have been filled. Almost all of them have been filled internally. We have a quality director who is we're lucky to get her. She came from Texas. We convinced her to stay. She's now a permanent county employee, and she's driving the quality results as well, which is important both from a perception standpoint and also from a liability standpoint. So there's a lot of good things happening there. It's the challenges that we have, just so you know, is from a labor perspective. We're just behind the 8 ball, and part of it is the expense that we have for the pension, part of it is the expense we have for the health benefits. So we're having to look in different ways to fill these positions because from a new nurse perspective, you're 25 years old. You don't think about retirement. You think about what's my paycheck to pay my house payment, my car payment, and my childcare. So, and then the other thing that, you know, if we can walk out of this meeting from a county perspective with something that we need help on, it's taken us 4.5 months to onboard an employee. It's taken us 4.5 months to onboard an employee, and we're losing 1 out of 2 nurses before they even start because of that time frame. So those are the things that will help us help you guys as much as we can. But the current wage structures that we have, you know, they're not even in the ballpark. So, for example, with the push for $25 an hour minimum wage, it's terrible for us, right? It'd kill us. But our competitors down the road, $200 grand because all their people are at that $25 as we speak, just to show you the gap that we have. Not an excuse, we can still perform without it, but there's some challenges that we can do better. You know, and all the people are joining. You know, we're taking the hiring process and we're breaking it down piece by piece to see how we could improve it. But part of it's just that civil service, that you have to interview the civil service people first, and the long list of things that are different from the other hospitals that we compete.
So not competing on a level playing field is kind of the.
Well, it's a
one of the
different playing
issues.
field. I don't want to say that, because dollar for dollar, we're probably spending as much as any other institution on our employees. It's just the allocation, the Dignity Health recently started charging not for the employee but the family. But in the last 30 years that I've done this, healthcare to all of our employees has always been absolutely no cost. And that was a recruitment thing. Here it's significant, but the pension costs are also significant, and that's different. So if you're a well thought out person and say, look, if I do my 25 years here, I'm going to benefit significantly, that's good. It's just that's not how most 25-year-olds think. And the market that we're looking at in the new nursing market is that 20 to 30 age group.
They want cash in pocket.
Cash in pocket. So we can pay for those car washes.
Yeah, our new grads will stick around for 1 or 2 years, then they'll get a gig at Sutter Health or, you know, Common Spirit.
So it's just a challenge.
So
No, and it's interesting, I went to Stanislaus State, so the new chancellor came down, and you know what I mean, and how do we partner with those folks to bring people, you know what I mean, and I think that's a step in the right direction, but we need to multiply that times 100, you know what I mean,
Yeah,
to
and again,
keep people local.
Yeah, keep them local. That's important.
So just to finish up on the revenue side, I mean, I can assure you we're doing everything we can to lift revenue outside of volume growth, and we'll continue to push forward with these initiatives. In terms of savings opportunities, we are seeing lower supply expenses now that we're leveraging the scale of Common Spirit with the Premier GPO. So that's been a huge lift to the bottom line. While we did see a reduction in overall traveler cost year over year, when we look at our professional services, we still have an enormous opportunity to bring down those 150 FTEs that you saw in the last slide, you know, in our hard to fill clinical departments. Any other savings?
Well, it's just, you know, a couple things that have taken time. So if you look at the bottom, another thing that we should be very proud of, and my background's lab, so I was amazed when I walked in there. We have the most state-of-the-art modern lab any hospital in California. And it's really amazing. And so we went back to the table with our group purchasing for Common Spirit. We were able to essentially replace the equipment that we have, add automation to the lab as a whole, and the savings was $7.5 million on the direct spend. So 2.5 a year for the next 3 years. So there's just some of the things that being in a bigger buying group helps. So.
I've got a couple questions just in general on the worksheet here. This, when you say 1 year successes, you're talking about the last fiscal year, 22, 23, is that?
Yes, successes and then ongoing initiatives as well. Some of these
Okay.
are in the early stages.
So the other thing is, I just happened, because the numbers looked pretty big, and I know they were ranges, I took the average of the ranges and added them up both on the revenue side, which came out to be roughly $60 million in revenue.
Right,
benefit.
one of the huge ones that we didn't get to is the Cerner Revenue Cycle Uplift Project. So my understanding is that when we implemented Cerner here at San Joaquin General, we did not do a post-implementation review to evaluate what was working and what was not after we implemented electronic health records. So that review has just initiated. We contracted with Cerner to review all the work lists and work queues within our revenue cycle teams. The Cerner team projects that we'll see a 15 to 20% revenue lift after this review is complete. That 20 to 25 million, Jay, is that the 15 to 20% lift that they projected seems very optimistic in my viewpoint.
Is that prospective or retrospective?
That's prospective, so
Okay.
that would be the annual lift.
Okay.
15 to 20% translates to $45 to $60 million in additional added revenue. That seems too high at this point. So that 20 to 25 million, I feel, is a reasonable target for us to chase once that assessment is complete. But it's a 12-month review, and it just kicked off in May. So we still have, a few more months here for that to be complete.
And the same thing when you look at the lab savings, that instrumentation won't be implemented until December, so we won't start seeing those savings.
So these are essentially a variety of completed, work in progress, started. Okay, because being the accountant that I am, I tried to add up, and then I looked and I came up with $88 million, and then I'm saying, great, they should have an unexpected gain, 88 million over what their budget was, and I can't do that because these are at various,
Can't do that yet.
okay.
We may have enough.
All right, I just
we may
wanted to
have
get
enough-
clear,
might have
keep you guys honest, that's all.
Might have enough to offset Jeff's pension hit next year. Hopefully it goes the other way, though.
All right, thanks for the clarity.
Just one more side here, Rick.
Yeah, this is just, again, like I said, my philosophy, when I went to my last hospital, it was the same thing. We had almost the same scenario, bad quality scores, leapfrog F, having financial troubles. We fixed the financials as quick as we can. We were a 10-hospital system, and I knew that for us to focus on the things that all of our people want to focus on, we couldn't have a financial burden. So we fixed the finances. We started focusing on quality. Leapfrog A, CMS 5-star after I think CMS took us about 4 years. Leapfrog A took us about 2. We're going to do the same thing here. Our Leapfrog score will at least be a C this time. By the fall of next year, an A along with everybody else, because it's a take-home test and we're focused on it. That's what this is really all about, and it's access. We're having challenges, so a couple of things that are really important. We don't have capacity. So our census today sits at 161. When we did the remodel, for whatever reason, we went from 200 beds to 150. We have a 25-bed locked prison unit, so obviously those beds are only used by, we can't use those empty beds for non-prison people. It wouldn't be good for patient satisfaction, let's just say. So we're challenged in space. And most importantly, the biggest opportunities for us are making sure that we run a much more efficient ED. We see volume anywhere from 120 to 200 in our emergency room. I think we can consistently be in the 180s if we can start flowing those patients. So we have some capital projects that they've approved that'll give us more room, but eventually we're going to have to address, the bed capacity is a problem, and it's a problem for this reason. We are probably in the year that I've been here, the year and 2 months that I've been here, there's probably been 3 days where our census was under that capacity, and the other 362 days significantly over, meaning our patients are being bedded in the ED sometimes for a day, sometimes for 2. And then the challenge from a community perspective is St. Joe's has the same problem. They're in the process of building a new tower, but that won't happen in my career, I promise you, because those things just take a long time. Dameron is I don't know their capacity number, but I know financially they have significant challenges. So from a bed capacity in Stockton, it's really important that we keep all of our available beds because everybody's
So
running
the
out of
leapfrog,
capacity.
what, I don't understand that, that's just
So
the
Leapfrog
grading.
is just an organization that measures quality throughout the hospitals. For whatever reason, they were the group that everybody picked because it's what, you know, people look at. Two things, CMS is obviously a CMS 5-star ratings is the federal government. That's the holy grail essentially, but they're time sensitive. Leapfrog is this is how you're doing right now. It's published. What we used to do in the very beginning is we wouldn't participate, thinking we don't care, right? And so when they showed the scores, it didn't matter, but what Leapfrog did is they went to the public data and graded you anyway. So you're kind of forced to play, but it is a good measure. And when you look at the things that they're looking at, it's exactly what you should be looking at from a patient perspective. It's outcomes. It doesn't matter what we do. What do our outcomes look like? How many times does our neurosurgical have an issue? How many times does our trauma have an issue?
So Supervisor Kennable, what Leapfrog is kind of like, if you wanted to use it as kind of a analogy, is that, you know, our S&P rating just got upgraded to a AA-, which is better than the A+, right? Leapfrog is essentially the same kind of thing for hospitals. And, you know, we'd be sporting an F on our financials, and what Rick is saying is we really weren't an F quality in many regards. Well, a lot of the things we have to do to keep our S&P rating up is we have to report. We have to tell them what we're doing. We have to give them financials. We have to, et cetera. If let's say Jeff said, I don't care about any of that, I just don't care. Who cares about S&P? And we had an F. Well, that's great until you go out and try to do a debt issuance, and then you've got a horrible credit rating.
Right, so then they still grade you if you don't, you're damned if you're doing, you're
Well,
damned if you
you know,
don't.
again,
So if you don't-
I don't, there's other companies out there. There's a company called Health Grades, and Health Grades can give you good grades, but they want you to participate to the tune of, you know, $500,000, and then they'll teach you how to do it. Well, you know, you're paying for a grade. Leapfrog is outcome driven, so it's the right place to be. We don't pay for it, and we should participate in those things. So it wasn't just that we weren't participating. We really didn't have a quality. Our quality people weren't on the floors, so they are now, because that's where they belong, watching how we take care of patients. So there's lots of big changes going on. We understand, believe me, we understand the need to perform financially, because otherwise it makes all of us, your job, my job, much, much more difficult. And we're doing everything we can from a cost perspective. Just from a nursing standpoint, you know, a couple things. We realize we're not gonna fill those 100 positions with the applicants out there. And just to give you an analogy, typically new grad applicants, we exceeded 300, 400, 500. This year we got 40, so it's a big challenge. So we're looking at other opportunities to bring large groups of people here, you know, on a more permanent basis. So 3-year traveling contracts at a rate that's very close to what our combined rate is. And I think that we did that in my hospital in Arroyo Grande. I believe those people are still there. They're part of the community. They're part of the union. They're part of everything that, you know, that we should appreciate, and it'll help us cut those rates significantly. So that's kind of where we are right now. As we still try to see what we can do on the contract side, we have CNA coming up in the fall or in the spring, and we really want to focus on that bottom range. You know, that's where we want to put our energy, on the CNA contract, so we can attract more people in that early age.
Okay, I want to make sure I kind of keep us near our time here.
Okay.
Did you
That
all
was our
have
final.
anything?
That was it.
Okay.
That was it.
That was it.
Any more questions for the hospital folks?
No, I'm just, back to that hiring thing though, how do we fix that? The 4-month thing, I mean, that's kind of alarming. I mean, thank you for all being here too, I just wanted to say that. I mean, I know it's probably not the best place that you all want to be in the morning, but as far as, you know, providing care and the bottom dollar for taxpayers and quality of service, it's important that we do have this so that there's, I mean, it's gonna get contentious, obviously, and I love your guys' passion, but those are the things that, you know, what can we do on our side, you know what I mean? And because we need bang for the buck, and you know what I mean? You know, we're obviously on a beer budget and champagne taste, so. So anyway.
I would just say that there's a couple of things, there's a couple of ways that you know, that we could, that probably are the lowest hanging fruit, and one of them, and they're working on it. And I don't really, just to be blunt, I'm not so much focused on non-clinicals, but if we could work on that turnaround time for onboarding. That would be really important to us. And in talking to, and everybody's been on board to do that. So I know they're breaking it down into little pieces so we can essentially, do it the way that we should to see where we can save some time, because that one's hurting us pretty significantly.
Okay. Anything else?
Well, I would just like to piggyback on the comments from the recruitment standpoint. We operate in the same market, and we're trying to recruit similar folks, as does Health Plan San Joaquin. I've had a number of monthly meetings with their CFO, and one of their concerns is recruitment for the region. So it's a marketing strategy that we need here, folks, and we need to make our positions more attractive to folks and incite movements into the area and attract the talent that we need, and confident we can do that as a team, for sure.
Yeah, because I'm on behavioral health too, and I mean, it's a struggle there everywhere we go. I mean, it's, how do you do that? How do you get people, and they're good jobs is what the more alarming thing. So I get it, and the battle of, living wage, and we went to the Kaiser Permanente thing on Labor Day, and you know what I mean? So you want what's best for your community, but I mean, it's also, keeping the money local, because us politicians need the money to run government. So it's important that, the traveling nurses and stuff, and, to keep them local like you're doing, and keeping the money spent local. So that's what's important to me. So thank you, guys.
You bet. Thank you.
All righty. I want to move on to our next item, which is public comment. Is there anyone here from the public? I don't see anyone. Okay. And then we'll move on to the last, no closed session. We have no closed session, so we will skip number 8. And then we'll go down to committee comments. Are there any additional comments from committee members we haven't made already?
Real quick, and so quality is an issue for our county as a whole, much as recruitment is, and I think they're highly related. So again, speaking with the CFO of Health Plan San Joaquin, for example, the state of California has now implemented preemptive sanctions. Not even, let's see what your results are for the year. Your year has begun, here are your sanctions for the quality scores produced by their providers. So just wanted to give you that nugget.
Thank you, Chris. Any other comments or questions from committee members?
Just one. And I think you nailed it. Quality care is the goal here. Quality care in a financially responsible way. And I just want to thank you for taking your time. I think we've got the right players on the field. We just got to figure out how we provide more services, how the hospital gets more revenue, and move forward. So Jay will spend about 2 weeks explaining this to me afterwards, exactly how this works. So thank you.
Well, that's a great segue, Supervisor Ding. And I'll close it out with my final comment here. I did find my document. I just, for everybody's edification, get it into the record. It is, this is the co-applicant agreement between the clinics and the county, okay? So we are co-applicants, and it says it's section 3.2A, the composition of the Healthcare Services Review Project Review Committee is composed of 2 county supervisors, the county administrator, the assistant county administrator, the senior deputy county administrator assigned to the clinics, county counsel, deputy county counsel assigned to the clinics, the auditor controller, the San Joaquin general CEO and CFO, the San Joaquin County Clinics CEO, who our interim could not be here today, and the CFO, who is Chris. So that's why we have the configuration that we have, and I appreciate everybody's participation. The last thing I wanted to do, and I just want to take a couple minutes because I think it's worth it, especially for the 2 new supervisors. As Supervisor Ding said, we'll be spending some quality time, but for the record, there are 2 governing documents that are kind of running the show here. One of them is where this came from, and it's called the co-applicant agreement between the county and the clinics. And so we have that co-applicant agreement to establish the FQHC lookalike. the history behind that, and it happened actually right before I came on board, was in 2012. And what happened is we established a 501c3 organization so that we could capture the lookalike status for our FQHCs and essentially get better reimbursements and supplements and all the other stuff. So we set that up, and we didn't really do it the way we should have done it, okay? It never came out of the box properly. And the clinics became folded into the hospital as a department, and they really shouldn't have been. And even though they functioned separately, they were functioning technically as a department, and their financials were combined with the hospital's financials, which they never should have been. I won't get into how it happened, but in 2020, it got picked up by our external auditors, and they said your fiscal stuff has to be separated, which is when Chris came on board, and we kind of broke that out. We really broke it out, and we can debate that at another meeting, but we got really separate. And so what happened was we started functioning as two different units when we still have a co-applicant situation here. And that's kind of when this meeting dissolved about a year ago. And as we took a closer look at what the requirements are in the co-applicant agreement, we said we need to start bringing things back together, which is why we're here. We also have some open issues we'll be discussing in future meetings. We have an interim CEO, okay, to go ahead and get a permanent CEO according to this co-applicant document, and two of you supervisors are on the liaison committee. There are 5 people on that liaison committee. You two supervisors, two board members from the clinics board, and the CEO, which I guess will be the interim CEO now as the 5th member. That liaison committee will develop a selection committee for the CEO out of those same members. We have not appointed that yet, that's a to-do. And then that committee will source whoever the candidates are gonna be. I believe it has to be at least 2 candidates and maybe 3, and those will go in front of the clinics board and for a final selection.
That's correct, Jay.
Yeah, so there's a lot in front of us. We're being very, very compliant for the first time ever, so I appreciate everybody's hand in that. And then as Rick had pointed out earlier, there is an MOU that's not only driving the QIP division, but also, as Chris had mentioned, the amount of services that are being provisioned from the hospital into the clinics. Now, the 3 of us, if you think about it, and when I say us, I'm talking about the county, the clinics, and the hospital are like triangular partners, okay? That's why we're all here. And so we have to operate collaboratively. The hospital is a component unit of the county, but the clinics are kind of a sort of component unit of our healthcare services department. We actually have a budgeted department that fits up in there.
I just wanted to, for our Board of Soups, our financials are not featured in the audited financial statements of the county currently. And I wanted you to know that as a function of our separation.
Yeah. While about 2/3 of your expenses run through as a pass-through through healthcare services,
That's
they're
right.
eliminated, I believe, you would know, technically as a fiduciary fund, and they're not included. So Chris is
We receive a
absolutely right.
bill each month for all of the labor that we purchase through the county, and we pay it same day.
Yep.
Well, we found that when we didn't pass your budget, though, you needed money.
Yeah.
Yeah, exactly.
That
right.
would help.
You need us a little bit.
So we're all tethered together, which is why we're all here, to bring it all home. So and we'll start working through some of the issues and challenges that we've had, and some of the things where we may not see eye to eye as we go forward, but this is the group that's gonna do it. All right? And with that, I'm gonna conclude the meeting. Meeting adjourned.
Thank